I'm pleased to be here with you today. My name is Dr. Bob Carter. I'm Chief of Neurosurgery at Mass General Hospital. And today I'd like to tell you about a cell therapy for Parkinson's disease that my team has been working on. It's a great pleasure to introduce you to this topic. As you know, Parkinson's involves the loss of dopamine-producing neurons in a critical area of the brain, the substantia nigra and the dorsal striatum. And this nigrostriatal pathway loss of dopamine production leads to problems like akinesia, rigidity, and tremor, a very devastating and debilitating neurological illness. We've conceptualized the idea of replacing those lost dopamine-producing neurons by using a cell therapy approach. The idea is to reprogram the patient's own skin cells, convert those to induced pluripotent stem cells, and then create dopamine-producing neurons for transplantation back into the brain in the critical areas of the striatum where the dopamine has been lost. There are a few questions that come up with this approach. Can we do this efficiently? And can we do it at scale? Can we eliminate any undifferentiated cells, which is a critical safety issue for this type of cell therapy? And also, is the cell product effective in our preclinical models? We're also interested to know whether or not we can improve the survival of the transplanted cells once they are placed into the patient's brain. And then lastly, does the autologous approach, the approach where we take the patient's own cells, offer distinct advantages over an allogeneic approach where we're using another cell source for this transplanted cells? And we've set out to answer each of these questions as part of our preparatory studies. The key innovations that I'd like to highlight for you today is one, the use of the autologous cells themselves, the patient's own cells, and the goal here is to actually reduce the immune response to the transplanted cells, increasing their survival and their effectiveness. We've also developed some novel strategies around metabolic reprogramming of the autologous fibroblasts and to create the iPSCs to improve the efficiency of that process. We've developed some unique culturing techniques which will allow us to take this up to scale production for a larger number of patients with high efficiency, and actually some additional strategies which involve elimination of undifferentiated cells using the Quercetin treatment, which inhibits cells that are actually prone to divide once they're delivered into the patient. And then finally, we've developed some novel transplantation techniques at the surgery side to develop columnar transplantation. And I'd like to highlight a little bit about each of these techniques for you in my talk today. First off, let me tell you a little bit about how we reprogram fibroblasts, autologous fibroblasts to iPSCs using a novel addition of 2 additional microRNAs in addition to the Yamanaka factors, which are well known for this reprogramming process. Through a set of basic scientific experiments, we've discovered that the addition of these microRNAs, which actually create a metabolic-driven process to allow for iPSC reprogramming, increases the efficiency of this process greatly. And this technique, by utilizing this increased efficiency, very much lowers the mutational burden and reduces the risk of cancer-causing alterations in genomic integrity when we're doing the transformation of the cells. These created cell lines actually demonstrate excellent phenotypic marker profile as we convert them out into being dopamine-producing neurons. Second innovation is the use of high-yield spot cultures. These promote the scalability and viability of the final cell product. There's reduced cell loss when we utilize this technique, and the spotting culture technique increases the number of cells that are viable for implantation into the patient. We've also tested that the cell product in a frozen state or the fresh state has equal efficacy, and when delivered, can be scaled in a way that is suitable for every patient. A third innovation is the use of Quercetin. iPSCs in their most undifferentiated state have the capacity to form teratomas or their precursor lesion rosettes. Quercetin involves the inhibition of the survivin pathway and actually causes apoptosis of these undifferentiated cells. And there's some novel IP around this that we've created to develop Quercetin as a treatment for elimination of undifferentiated cells in the actual cell product. And our basic science shows us that once we've given this Quercetin treatment and eliminated the undifferentiated cells, there's an extremely low likelihood of any surviving cells that have capacity for cell division upon implantation into the patient, increasing the safety of the approach. A fourth innovation is techniques that we've developed to improve graft survival. We've been very interested to try to improve the survival In the typical bolus injection of cells once delivered, there's often tissue disruption at the site of delivery, and the central part of the graft often exhibits signs of hypoxia and necrosis. In a columnar technique, using a new device that we've developed, we deposit the cells in a column as the target injection needle is withdrawn. This increases the surface area to volume ratio and improves the oxygenation of the graft, and our data shows that it improves the survival of the cells once delivered. This columnar injection technique and the improved survival minimizes local trauma at the delivery site. Now, there's another important innovation, which is the autologous approach itself. The concept here is to use the patient's own cells and to reduce immunoreactivity against the graft. The idea here is that we would avoid using immunosuppression after transplantation in these patients. And notably, in our first patient that we treated, and published this in the New England Journal of Medicine in early 2020, we showed that this patient's cells, once transplanted, no longer exhibited any reactivity in terms of his autoimmune response to the survival of the cells and improved the survival of the cells. And what we've seen in our animal models is that this bears out. And in this first patient, this also proved to be the case, that we were able to see that the graft had good survival, as you can see on the PET scan images at the bottom. And this is an image from our first surgery, which was accomplished at Mass General in this proof of principle patient that we treated. So what are the opportunities and future directions for this approach and next steps? We're completing our enabling studies for a phase 1 safety trial, including expanded CRO animal safety studies with multiple patient lines. And fibroblast programming is underway at this time as well, in terms of doing a study where we're assessing the ability to program cells from a wide variety of patients. We are streamlining our cell production pipeline and our quality assurance pipeline, and also building our production capacity with a new facility at Mass General for producing these cell lines in multiple patients simultaneously. Of course, we're seeking academic and industry collaborations to move this work forward. It's been a real pleasure to update you on this concept of cell therapy for Parkinson's, and we look forward to further conversations. Thank you.